Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
We're very excited today to have our guest, Dr. John Kotter. Dr. Kotter is a cardiologist at the University of Kentucky, and he's the medical director of the Echo Lab and cardiovascular research. And we're doing this in February in honor of American Heart Month.
Our goal today is just to help you better understand cardiovascular disease in general. We want to give you insight to what maybe your primary care doctor is telling you or your cardiologist when they are recommending different aspects of lifestyle as well as testing or medicines in order to reduce your risk of a heart attack. And we really are wanting to empower you with this knowledge so you can have those informed conversations with your doctor. To get us started, Dr. Kotter, can you just tell us a little bit more about yourself?
Yeah, Sarah, Kitty, thank you so much for letting me come and talk with you and your listeners today. So like you said, my name's John Kotter. I'm originally from Utah. I went to medical school at the University of Utah, and 15 or 16 years ago, I moved to Kentucky and did my training here in general medicine, and then I stayed to do cardiovascular medicine. And for the last few years, I've been really involved here at the university in teaching medical students, residents, and fellows some of the nuances and particulars about cardiovascular medicine. I've been trying to do more and more of my career based off of prevention as well as imaging as a way of hopefully being able to see problems before they become too hard to treat.
I think one of the first things that would be good for people to hear is when someone is talking with their primary care doctor or their cardiologist, depending on whether or not they have one, what do you feel like is important for people to really be aware of in their own history, family history? What should people know about their own heart health?
Yeah, I think as you come to see a cardiologist or you're talking to your heart doctor, you're worried a lot of times about lots of things are going through your mind. It's kind of one of these specialties, I think maybe a little bit like an oncologist. There's just something about something maybe being wrong with your heart that gives you a little extra level of anxiety or nervousness. And maybe it makes it harder for you to communicate what it is that you're feeling. I think actually going in with a clear idea of what it is that you're after can be really helpful. So are you worried about, here's my long-term problem. I'm doing perfectly fine today. I'm worried about making sure that I live as healthy as I can for as long as I can. Or is it, I've started to notice these symptoms. Are these things something that I need to worry about? Is it something that I need to do something about? Do I need this to be addressed? I think once you kind of have a better sense of where you're at with that question, then you can frame things. If you're already having problems, it probably doesn't matter as much if your grandfather had an issue with heart attacks or strokes, because you're having a problem right now. We need to worry about you. But if this is something where you're worried about my long-term health and you're doing very well, then knowing, boy, my brothers and sisters, do they have any problems? Do my other primary family members, my parents, my grandfather, grandparents, do they have issues? I think really knowing a good family history of who has had what problems can be tremendously helpful for you understanding your risk.
And to kind of distinguish that, because I notice this a lot in primary care, is helping people understand the difference in risk based off of age for their relatives and if they had different conditions, and what conditions related to the heart are we most concerned about being possibly genetic.
Yeah, for things that go along with genetics or age, I think saying things like a heart attack or a stroke at a young age, which to me means less than 55 years old, that's something that should raise red flags. Anybody that passes away unexpectedly for any reason should be worth noting. So somebody's in their 30s, 40s, 50s, they die in their sleep. Even if it's in a car accident, it's worth talking about that with your primary care provider. Sometimes people can have something that leads to the accident and it just gets attributed to an accident. So anybody that's passing away at young ages like that, I think, is worth talking about.
And, obviously, if someone has known heart disease going on, they're going to see a cardiologist. But for the person that's not experiencing any current cardiac issues, but maybe does have a family history or just wants to talk to a cardiologist to kind of get a better idea of their risk of cardiac disease in their lifetime, is that reasonable? That was sometimes a request I got from patients that weren't having an issue, but they really wanted to hear about it from a cardiologist as opposed to their primary care doctor about their risk.
Yeah, I think it's reasonable. These are things that everybody's different. It's kind of what depends, on the person and who you are and who you like to listen to. If I have a good relationship with my primary care person, they know me, they know my medical history, they know my concerns. I think cardiovascular prevention is something that a primary care person can talk to me about perfectly well, that I don't need to see a cardiologist. Sometimes some cardiologists want to do maybe more testing than what you really need to do. So they feel like, here's somebody here, I need to do some testing to help them. And maybe that isn't always the necessary thing to do. If you don't have a good relationship with your primary care person and you feel like you're maybe being dismissed or you feel like your questions aren't being answered and you want to see somebody else, then of course a cardiologist is a reasonable person, but it might just be a different primary care person might also be a good option for you.
Tell me, what are the most common misconceptions you hear from your patients about the heart?
I think people oftentimes feel like they don't have control over their own disease. So people with heart disease, they can manage most problems incredibly well with a combination of diet, exercise, and medication. And using those three tools all together can be very empowering. I think a lot of times both physicians and patients might misunderstand that only one of those elements is the key. Oh, sure, change your diet and eat better, this will all be better. Or just take all your medicines, this will all be better. I think really using those three things together can make a huge difference for patients in managing their disease and changing something, maybe not changing something, but for making something that's scary into something that's very manageable. I think another common misconception with cardiovascular disease is that you can have something that is terminal that really isn't terminal. Meaning, we've all had family members that have had a heart attack and they pass away. And so you think now, if I have a heart attack, that's the end. I'm just gonna die from this. But so many really serious, complicated things that you don't want to have, but if you have them, if you have a heart attack, if you have heart failure, these things can really be managed to where you can live a long time, good quality of life. They're really diseases that doesn't just mean, start racking up credit card debt.
Right. And we're going to talk a lot today about prevention of these diseases, but I think that really brings up a great point. If you have had a heart attack or you have known heart disease, yes, you still have a lot of control over how your life goes from here on out. And that's, taking your medicines correctly, being compliant with that, but also doing these other things, diet and exercise, and just really taking responsibility and getting that control. You can still live a really wonderful, happy life. So I think that's a great way to think about it. Can you tell people quickly, too, the difference between a heart attack and heart failure? Because I think that gets confused sometimes.
Yeah. So on the simplest level, your heart is a pump. Your heart pumps blood, well, it's really two pumps. The right side of your heart pumps blood to your lungs. It drops off carbon dioxide, picks up oxygen, comes to the left side of the heart. The left side of the heart pumps that blood out to wherever it needs to go. Your brain, your muscles, delivers the oxygen, picks up carbon dioxide, and it goes in a cycle. In order for your heart muscle to pump normally, just like any other engine, it needs its own fuel supply. So as a part of that, the heart pumps blood to itself. It does this through arteries called your coronary arteries. These arteries deliver the nutrients that your heart muscle needs to keep working. If those arteries get blocked and it disrupts the blood flow to the heart muscle itself, now the heart muscle doesn't get the nutrition and oxygen supply that it needs, and those cells that are dependent on that, they become what we call ischemic. They don't get enough oxygen, and if it's prolonged long enough, they die. That's a heart attack, where your arteries become blocked acutely. The heart muscle doesn't get enough oxygen. That heart tissue dies. When that heart tissue dies, it no longer is able to pump normally. So now you have a decreased pumping ability from the heart. Anything that leads to decreased pumping is something that can lead to heart failure. So a heart attack might be a cause of heart failure, but you could have another reason where the muscle itself becomes affected, maybe from a different disease. And if the heart muscle stops pumping normally, now you could exhibit symptoms of what we call heart failure.
So you could have a heart attack that affects maybe a small portion of the muscle, and that doesn't have a big effect on the whole pumping. So you could have a heart attack that doesn't cause heart failure, or you could have a heart attack that does cause heart failure, or you could have heart failure without a heart attack. So all different possibilities.
Exactly right.
And another thing we want to clarify for all of our listeners today is when we talk about heart health, that in general, there's many different conditions that can impact our heart. Today's focus, and when we talk about primary prevention, we're focusing on that coronary artery disease. And so we just want you to realize that, because all these things for lifestyle that we're going to be talking about is focusing on that specific condition and not some of the less common things like arrhythmias or different cardiomyopathies, etc. So we just want to be sure we're all on the same page of the condition related to the heart that we're talking about today.
Yeah, and what Sarah's saying, there's funny heart rhythms, or where the muscle of your heart starts having problems and can't function for other reasons. So primarily we're talking about, we don't want you to have a heart attack, and that's what we're going to focus on as much as we can. Dr. Kotter, when you are thinking about a patient's risk, and you're looking, maybe you're seeing them for the first time, they're coming with some labs and other things that they've done with their primary care doctor, what are you really looking at to kind of think about the risk that that person has of a heart attack?
Yeah, I think risk is such a hard thing for people to understand. You're kind of in the back of your mind, you're like, well, risk, what does risk mean? And that's really what we care about is your chance of having a heart attack really, really high, really low. And that constitutes risk. I sometimes think about this a little bit like car insurance. I have a 17-year-old son who just recently started driving. And I know all about car insurance risk and rates and these sort of things. But it's like going forward, you don't know, am I going to be in a car accident or not? Is my risk high, low, or normal? You don't know for sure. But there are features that make it where you say, oh, my risk is really high. So if you knew you were going to drive your car in a demolition derby, you'd be like, my risk is really, really high. Now, I don't think you can do that for insurance, but for the story, that's really, really high risk. Or you say, look, here's a new 17-year-old driver driving in a snowstorm. That's high risk. Or maybe you have somebody who's driven for 20 years and they have a car that they drive back and forth to work for 20 minutes a week on very, very, open roads. That's a very low risk situation. And so cardiovascular disease prevention, I think, is similar, is you're trying to say, I don't know what the future holds for people, but do I think this person's risk is really, really high? Is it pretty normal, which we don't just say a normal risk, but it's risk, or is this person's risk lower than usual? And so in order to get a sense of what your risk is, we have lots of different pieces that we look at. And I think this makes it complicated for people because We don't ever actually say, here's your risk is just this, because we don't know that really perfectly well in medicine. So we put all these things together. And so some of these things that really determine your risk are things we talk a lot about, like your family history. If you knew in your family, boy, every one of my parents, grandparents along the line, they all have a heart attack when they're 40 years old. Boy, your risk is really high. We know other things influence risk. So if you smoke tobacco, your risk is higher than if you don't smoke. If you've never smoked, your risk is a little bit lower than if you've smoked and quit, but not much. Quitting smoking really decreases your risk pretty quickly back to what it is if you're not smoking. We know people that have higher blood pressure, your risk of having heart disease over the long term is higher than if your blood pressure is normal. People who have high cholesterol, especially forms of bad cholesterol that we'll probably talk about, that means your risk is higher. Can you have high cholesterol for a long time and never have a heart attack? Yes, that happens all the time. But your risk is higher with high cholesterol. Other things that impact risk, some of it is dietary changes. People that eat a plant-based diet are lower risk to have cardiovascular concerns than people that eat really high carbohydrate or high processed food diets. Regular exercise is another thing that functions into a risk calculator. People who are overweight have higher risks of cardiovascular disease. And then there's other things that I think a lot of times we don't think about. Patients that are lonely have higher risk of cardiovascular disease than people with good social structure. So I think when we talk about cardiovascular risk, we're putting a lot of these things into context, putting them together and getting kind of a sense for an individual. Okay, is that person's risk high, low, normal? And even if it's high, that doesn't mean that you're not guaranteed to have a heart attack. If it's low, you're not guaranteed not to have a heart attack. It just makes things a little bit more likely, a little bit less likely. And so what we want to do is we want to encourage all of our patients, all of our listeners to say, what are these things that I can manage to take my risk and make it lower, especially by doing something that doesn't add, extra expense or extra challenge or extra side effects as a trade-off.
I think that is an excellent overview because I know many times that I've had patients come to me feel like the only thing that's being discussed about their heart health is one number. We can go into this at this point, but everything seems to only be influenced by their LDL, and they're not getting any advice on how to improve their heart health other than that one specific number. We know it does play into their heart health. So could you just give us a little bit of your thoughts on that piece? And then we'll go into all these other different risk factors. But how does a high LDL impact someone's cardiac health?
Yeah, simplicity is like the best thing in the world. It's like when there's one thing you can focus on, you're like, great, I can take care of that, I can handle that. And if only it were that simple, it would be fantastic. And LDL, I think, is one of those things people want to be that way, but it probably just isn't that good. So if your LDL is really, really high, meaning it's higher than 190, then it probably is high enough to say your overall risk is high enough where it's worth working on diet, exercise, and medicine. But if it's less than 190 and you don't have any evidence of other heart disease, then I think you really do need to be thoughtful. And so it's that being thoughtful group that is worth talking to somebody about, thinking through things, and looking at more pieces than just a simple number. There are a lot of different calculators that you can use that actually help to refine your risk a little bit better. One of the most common ones that's used is something called an ASCVD, like AS, atherosclerosis, CVD, cardiovascular disease calculator. And you can Google this, and it'll ask you for about 7 points of information, and LDL is one of them. And as your LDL changes, you can see how your risk changes. But I think using a calculator like that, or there's some other lifestyle calculators that are becoming more usable, I think it gives you a better picture because it's more than just one element. LDL is important, and it shouldn't just be ignored. But it's only one part of a big picture.
And I think that ASCVD risk calculator is what most primary care and cardiologists are using as far as their recommendations on medications. And that's really looking at what's your chance of having a heart attack in the next 10 years. So obviously something to take along with that is if you're calculating your risk score of that 10-year risk of heart attack when you're 35 versus your risk when you're 75, even with the same numbers or even better numbers at 75, that risk is going to be higher. So there's certain things that you can't change, like your age and your sex and those risk factors that could make your score higher or lower. So remember, if you're someone, let's say that's young, 30s, 40s, and you're thinking about, I really want to reduce my chance of heart attack in the long term as much as I possibly can, your risk may be a little low, kind of a false sense of security just because your chance of having a heart attack at that young age is small. So don't think just because your risk is not so bad that you don't need to do these things to keep that being low each 10 years that you're checking it. And just because your risk is a little bit elevated when you're older doesn't necessarily mean you've been doing anything wrong, but your risk of heart attack is going to go up as you get older either way. So it's kind of a way to give us as providers a direction as far as what we're prescribing, but realize there's a lot of nuance to that when you're looking at it yourself. And I'll put a link in our show notes so that you can play with your own calculator and look at where your risk falls and how you could maybe make it better.
And I think for some of this younger, because using the calculator in your 30s you're not even supposed to use the risk calculator when you're that young. What kind of view of your LDL, if you have it checked in your 20s or 30s, like what should you be using other than looking for that above 190? If you have higher numbers, does that mean you should talk to your doctor about medicines? Does that mean you should be more aggressive with lifestyle? What kind of advice do you tend to give people in that really young age group?
Yes, I think it depends on the person. It really is talking to them about it. So first and most important, if your cholesterol, if your LDL is, 20s, 30s is quite high, it is important to ask if any of your family members have had heart attacks at a young age. Because those two things, if your LDL's high when you're young and you've had family members with heart attacks before their 50s, 60s, that's a higher risk situation. And so that gets treated differently. If you're 25 years old and your LDL is 160 and there's no family history of early cardiovascular events, then some people are going to look at their risk and say, okay, medicine is worth it to me. And some people are going to say, I don't want to do medicine because of side effects or other concerns, cost. I'm going to really focus on diet and exercise. And I think both of those can be really reasonable approaches for someone. It really depends on somebody's values. And I think this goes back to where we started of saying, it's worth having a primary care person that you trust, that you can talk through things, because both decisions are very reasonable. It just depends on what you want and what you are trying to accomplish. So I'll throw myself out as an example. So I would say I am pretty good at healthy lifestyle. Am I perfect? Absolutely not. But I don't smoke. I try and exercise pretty regularly. I try and maintain normal weight. I eat mostly plants. I'm not perfect, but I do pretty good. And the last time I had my LDL checked, or my total cholesterol was a little over 200, and my LDL was 150. My HDL was a little bit low. I don't remember it. And my overall risk isn't high, but I was like, oh, that cholesterol is higher than what I want it to be. That's not where I want it to be. But for me, I really didn't want to start medicine. I felt like if I started medicine, my LDL would get better, but my overall risk isn't going to change super dramatically. And I was like, well, I'm going to really focus on having discussions with my physician about this. I'm going to focus on really aggressive lifestyle changes, even though I was already doing things. So I looked at a few things that I thought I could do a little bit better with this, and I did better. I focused on cutting out some sugar. I focused on a little bit better, more routine exercise, and my LDL got better. Is it where I want it to be? No, it's not perfect. Like I think it's in its 120s now. But for me, I'm like, okay, that's very acceptable. Now, as I get older and I'm going to keep looking at this and keep looking at my risk, could it be that I end up starting medicine for this in the next years? Yeah, maybe. So I think that's also a good point, is that you don't have to say, just because what you do today, that doesn't mean you've committed to do that for the next 10 years. You can always revisit this. Things change, your priorities change, lifestyle features might change depending on what's going on with you in your life that change some of your decision making.
And we know that as you age, you can develop other chronic conditions that can increase your risks, such as like autoimmune conditions or type 2 diabetes. So all those things have to be taken into play as well when you're making that decision regarding managing your cholesterol.
Yeah. And vice versa too, what you said as well. People should definitely know if they start a medicine, you can stop it. If you decide you finally get to a place in your head where you're ready to commit to lifestyle, but you have been on medicine, that's definitely something you can try. You may find when you stop it that you can do all the things and you still need it. But some people may find that they can stop it and do all the right things and not need it. So yeah, you can change your mind on how you want to do things. Tell us a little bit about other screenings where we're looking at images like vascular screenings, so coronary artery calcium scores or carotid ultrasounds. Are those things that you think are helpful when people are trying to understand their own risk?
Yeah, I think it goes back to that same point about risk. If you already know you're high risk, then doing something like that isn't going to tell you anything you don't know. And if you already know, look, for whatever reason, I am not going to act on this information that I get. I mean, we all have our own opinions about things. And so if you're like, no matter what it shows, I'm not going to do anything different, well, then it's silly to look. But if you find yourself in a situation where you're kind of in an intermediate risk zone and you're trying to decide, is this something that I'm going to do differently? Am I going to add medicine? Or am I going to change my diet structure based on a result like this? Then sometimes these imaging tests can be a nice nuance for somebody in the middle. So, like, I think to use, again, myself as a good example. So here I had this LDL of 150, and I was really trying to decide if I was going to take a statin. And if I did something like a calcium score and it showed no calcium, then I'd feel very, very comfortable saying, I'm not going to take medicine. I'm going to continue doing what I'm going to do. If it showed evidence of calcium, which is really just a marker of cardiovascular disease building up in your coronary arteries, if I saw that there was a lot there, and then I was going to take a medicine, well, that fills a very nice role of helping you make a good decision. That being said, for most patients can refine their risk really well based off of other risk factors like we talked about, the things that go into that calculator. And you can get a good sense of if you should or shouldn't be doing a comprehensive treatment strategy. But for the right person in the middle zone, those tests can be very helpful. That being said, you have to be careful. There are some tests that are offered to people as a way of trying to either scare patients into being treated. So they'll offer an ultrasound treatment looking for plaque in your carotid arteries or a calcium score as a way of trying to encourage people to do more testing and more treatment. So I think having a plan ahead of time and knowing what this test means for you and what the reasons are of why you're getting it done are important instead of just doing things and then reacting to an abnormal test.
I think that's great because these tests are now being advertised to individuals without really having a doctor involved. And so many times you have this information and then you have no idea what to do with it. And so it's really advisable to be doing these tests with your doctor instead of on your just getting multiple different screenings and not knowing what to do with the information.
The other thing I would see a lot is some of these screenings, the companies and they're going just directly to the patient, as then they would tell them they need to repeat it every year, and that person's paying to do that every year, where a lot of these things change very slowly over time. And so paying to repeat that every year is really a big waste of your money. So I think if you do end up doing one of these screenings, definitely bring it to your primary care doctor, talk to them about it, talk to them about whether you need to do any additional testing or if you ever need to repeat this and when that would be if you did.
I think that's such a great point. It is so uncommon that you need to repeat a calcium score or an ultrasound of blood vessels. If your symptoms haven't changed, you usually can get what you need from that information for a long time forward.
I know a common misconception I have heard from patients, if you could speak on this, is they've had just an EKG in a doctor's office for whatever reason, and they feel like, that's normal, I'm okay. But when we're talking about coronary artery disease, can you just reflect on how that isn't always a good indicator of that?
Yeah, so if you think about an EKG really is a good test of the electrical system of the heart as far as what's happening right at that very minute. And so if you're doing well and not having any problems, any symptoms, an EKG is very unlikely to detect something that's deeper down that it can't see that very well. So an EKG can be helpful when you're having symptoms, but it's not a guarantee of cardiovascular health because something is good in the moment. A lot of times I think it's a little bit like a home inspection. You have a home inspector come, you're getting a new house, and you're worried about the plumbing of the house. If all the faucets, turn off and turn on, that's good. It's better than having leaky faucets. But you really don't know the health of the pipes. So it's, 2 years later when one of the drains is clogged, there probably was evidence of that before when the home inspector came. And if the home inspector would have done a test that looked at that, they probably would have seen that. But you need the right test to determine the right answer.
Yeah, and I think I used to get a lot of questions about why an EKG wasn't included in the physical exam, just someone's routine annual exam. I think at one point, maybe prior to our time of practicing, insurance did cover that and it was common practice. But nowadays, it's not something that's covered in just the general routine annual exam. And I think it speaks to what you were just saying, is it can give a false sense of reassurance. So really, unless you're having an issue, looking at the EKG is probably, there are exceptions to this rule for sure, but it's probably not going to be giving you much useful information. And I think I get the same question. I think a lot of people feel a sense of reassurance when they've had an echo as well, which I know is one of your loves.
Yes.
So can you speak to also what an echo shows and what it doesn't show?
Yeah, so a cardiac echocardiogram is an ultrasound test of your heart. So with the ultrasound, you're able to see the heart. You can see how well it's squeezing. You can see all the valves. You can see different features of cardiovascular health. You are not able to see the arteries that supply the heart. So sometimes on an ultrasound, you can see indirect evidence of cardiovascular problems, like you could maybe detect that there's been a heart attack that has happened, but you're not able to see the arteries well enough to know if there's disease or blockages in any of the arteries with an ultrasound. It's a good test for certain things. If you're having a murmur, it's going to be a perfect thing to help let you know if your valves are normal or what the cause of the murmur might be. But an ultrasound or an echo isn't a great test to let you know the overall health of your arteries inside your heart.
So again, we're just trying to help you all understand using these different tests and looking for prevention versus assessing symptoms. And you will get different tests from your doctor based off that, whether or not we're just trying to look at your overall risk versus you're coming in and saying, I have X, Y, or Z symptom. You may get a completely different type of cardiac test.
All the different tests show different things, so they all have different reasons to be performed. So just because you have one of those tests, don't necessarily think you're good on all fronts as far as the heart goes. A lot of people are wearing new devices like their Apple Watch or other devices and looking at their heart rhythms at home. Do you have any opinions on that? Should that be something they share with their doctor? How accurate do those seem to you?
Yeah, so I think almost everybody is wearing a monitor that's able to keep track of their heart rate. As I look at the three of us here talking today, all three of us have a watch that will tell us different things about our heart rate or rhythm. That being said, I think wearable monitors for more patients are a cause of anxiety than of anything useful. So it is common. In fact, almost everyone that wears heart monitor for the course of a week, where we're actually looking at every beat, almost every single person will have some irregular heartbeats. We call these usually premature atrial complexes or premature ventricular complexes. They're not normal, meaning most of the time you don't have them, and yet they are totally benign. Everybody has these things. Some people can be slightly symptomatic. They'll notice that their heart flutters or their heart skips a beat, but they're not dangerous at all. And yet, when somebody wears a watch and the watch alerts them and it says, oh, you have an irregular heart rhythm, your heart is skipping beats, it can be a source of anxiety. And now people can become focused on it. And just that conscious awareness that this is happening and being anxious about it and having some of your stress hormones and catecholamines now released, it can make these things a little bit more common. And so wearable monitors, if you are not having symptoms, I think can be a source of anxiety or maybe aren't helpful. If you're having different issues, different palpitations or fluttering of your heart, or you're worried about arrhythmias, then having a conversation with your physician about if it's worthwhile to use something besides just a wearable monitor, something else, if something else isn't necessary at all, I think is a reasonable discussion. Most of the time, you're more likely to get a false positive or anxiety from your watch than something that's going to be helpful.
And I know I've even had patients who have worn a prescribed Holter monitor, et cetera, and there's not correlations from what their watch is telling them and what the actual medical grade device is. So that's important to know.
Yeah. So if you're worried, talk to your doctor before you spend your own time having too much anxiety about it, because they may be able to give you some quick reassurance. And on the topic of people trying to be proactive about their health, what do you think are important things for people to really prioritize in their lifestyle to help?
Well, I feel terrible by answering this question for saying the first thing out of my mind is something you shouldn't be doing. I think it's better to focus on the positives. But still, the first thing when it comes to lifestyle is if you're smoking, do all you can do to quit smoking. Like avoiding tobacco is, I think, the most important lifestyle thing we can do for cardiovascular health. Smoking cigarettes is worse than other forms of nicotine, but no form of nicotine is good. But if you're able to say, I'm going to vape as a way to bridge to stop smoking, good. That's a bridge. You're headed in the right direction. But I think the first thing to do is to do all you can do to quit nicotine. Nicotine, when it comes to the heart, is unfair. So if you smoke 10 cigarettes, that is twice as bad for you as smoking 5 cigarettes for your lungs. But smoking a couple cigarettes is almost as bad as smoking a lot of cigarettes. So if you're somebody who smokes and you've cut back on smoking, good for you, that's good. But keep going all the way and finish those last few cigarettes. They make a big difference for your cardiovascular health. Outside of tobacco use, I think the other lifestyle things that make big differences are grouped into different categories. So some, I would say, are true lifestyle things. And these I really think of as being diet and exercise. And generally eating more plants and less things out of boxes and bags is the way to go about cardiovascular health for dietary choices. So do we have to be perfect? No. If you can be, great. But to say, okay, I'm going to eat more whole foods, more plants, less things that are processed, less things that are atherogenic, like complex carbohydrates and red meats, these sort of things are probably worth doing. That next group of exercise things to do, I think a really well-balanced exercise program makes a big difference. It's not just cardiovascular. Exercise is the key to cardiovascular health. So sure, it's an important, big component, but finding a way to do something where you're taking your heart rate and you're getting it to increase by, 30, 40% is fantastic. You don't have to be training for a marathon, but it's doing moderate exercise most days of the week. So moderate exercise, I would say, is getting your heart rate to increase, but probably not so much that you're sweating, and doing that for 30 minutes, 5 days a week. If you can do more than that, great. That's fantastic. More is better, but I think that's a great starting point, is to say, okay, I'm going to start by something simple that I can do, and I'm going to do a little bit more of it as I'm able. I don't need to figure out a way to commit 2 hours a day to doing this. 20 minutes, even if it's broken up into parts, can make a big difference. I also think adding some weight and strength training to that exercise program makes a big difference. So again, it's not that you're trying to set personal records for the amount of weight that you're lifting, but simple things that add some strength training. It's good for your overall health, whether it's balance and gait stability and bone health, but also certainly is helpful for your cardiovascular health. So one thing about exercise, I think exercise is tied in so many people's minds to weight loss. And for a lot of patients, you get motivated. It's like, oh, I'm going to start exercising. And you do a good job, and maybe you don't lose weight like you were hoping or expecting to. And then you get frustrated with this, and there's a tendency to want to quit or to give up, because sometimes exercise for a lot of people is really hard. If we could see the benefit that exercise was doing for our arteries on the inside, you would keep doing it. For one intervention that makes a bigger difference for the health of your arteries than anything else, it is just regular, simple exercise. So don't get frustrated when you aren't losing weight like you would like to. Know that the benefits of exercising are so much more than weight loss. It's good for your arteries, it's good for your sugar, it's good for your blood pressure, it's good for so many things you don't see, that regular exercise, even low intensity, not very much, not very often, is still really good for you. And being able to do a little bit more than that, to get a little bit more exercise a little bit more often, can make a big difference. So stick with it.
I love hearing that, because I know you probably get sick of Sarah and I talking about exercise all the time, but we're trying to bring it up in these different contexts so that you realize that, yes, exercise does not mean weight loss. So if you listen to our seasonal affective disorder episode, we were talking there about how much exercise can help with your mood. We've talked about how exercise can help with social connections. Realize exercise does not mean weight. I love that you said that, because I don't think we've said that very clearly. Exercise helps so many different systems.
And then other lifestyle things that I think are more like almost in this medical realm are things like maintaining normal blood pressure. So you don't know what your blood pressure is unless you're checking it. Your blood pressure can be low, it can be normal, it can be really high, and you can feel the same. But high blood pressure over years puts so much stress on your cardiovascular system that is such a high risk factor that can be easily modified and will really improve your risk. So the first step in knowing if you need to worry about your blood pressure is actually having a mechanism to check your blood pressure. When you go to the doctor, I think having your blood pressure checked is the most important thing that they do at the visit. And yet it can be done quite casually. So when you get your blood pressure checked, make sure it's being checked appropriately. So that should mean that you come into the office, you're actually sitting down, your feet are on the floor, you're resting quietly for a couple minutes, and they check your blood pressure. When somebody checks your blood pressure, it is okay to ask, what was my blood pressure? I think a lot of times, the person checking it just writes it down in the chart, it gets passed on to your doctor, and you don't even know what it is, and maybe they don't bring it up. So it is okay for you to say, hey, what was my blood pressure? For most people, you want that first number to be less than 130. There's some times where it can be a little bit higher than that, and it's okay. But in general, if it's higher than 130, it is worth having a conversation with your doctor about that number. If you're doing well and your blood pressure is always normal at every doctor's visit, checking your blood pressure at home, I would say, is not necessary, but it's also very reasonable. You might only be going to the doctor once or twice a year, but being able to check your blood pressure at home is one of these numbers that I think makes so much sense for your cardiovascular health. Like if you're listening to this and you're like, I know what my LDL is, well, your LDL is probably less risky to you than your blood pressure. And so knowing what your blood pressure is, I think is also is also very reasonable. So you can get a good blood pressure monitor from a drugstore, from Amazon. I think getting one that goes over your bicep, your upper part of your arm, is much better, even if a little bit less convenient than the cuffs that go on your wrist. But the same thing, using this blood pressure cuff, you don't need to be doing this every day. Though sometimes I find I can do something every day and I can remember to do it. If I do something, twice a week, it's hopeless for me. But having a system where it's like, okay, I'm going to check this once or twice a month if you're doing well and it's always normal. If it's not normal, then checking it more frequently or having a discussion with your doctor about how often to check it, I think makes a difference. But the same thing, you should put your blood pressure cuff on. You should sit in a chair with your both feet on the ground and your back supported, and you should sit there quietly for 5 minutes and then push the button to record your blood pressure. Poorly recorded blood pressure is not going to be helpful. You can have elevated blood pressure just because you've been up moving around, maybe you just had coffee, different reasons. So making sure your blood pressure is normal or is treated as normal is one of the most important things for cardiovascular health.
On that note, I many times have had patients that have elevated ones coming into the office, because many times if you go straight into a doctor's office, sit down, there was not a 5-minute rest period. So if that initial blood pressure was elevated, always saying, hey, can we check that again before I leave? Because that may be a better gauge of your true blood pressure. And so don't be afraid to ask for a recheck just to see how that impacts it once you've actually sat for longer.
I think that's so important. It's also, there's something called white coat hypertension, where your blood pressure can be high at the doctor's office, but it's normal when you're at home, when you're about doing regular things. And a lot of people think they have white coat hypertension because, it's high when I went to the doctor. I checked it once at home and it was normal. It is white coat hypertension, and you don't worry about it. I think when you've been told you have white coat hypertension, you should be involved enough in your healthcare to say, I'm going to make sure this is still true. I'm really going to monitor at home, because more often than not, when your blood pressure is elevated in the doctor's office, when it's done appropriately, your blood pressure could be elevated at other times. So don't just attribute, my blood pressure's high when I go to the doctor. It's normal all the other times, unless you really do know that it's normal at these other times. And you
probably, even if you don't have a cuff to use at home, you probably know someone that does. Or for a while, those the blood pressure cuffs went away at the drugstores during COVID, but I think they're back at the grocery and drugstores now. So if you want to, you can just check them when you're there too. But again, make sure you haven't been zooming around the store and then sit down quickly. You still need to take that minute to relax before you check it there too. I would love to get your thoughts on something that used to be really widely thought of as a definite preventive strategy for people, which was aspirin. And things have kind of changed in the last few years with recommendations on that. It used to be every man over 50 should take a baby aspirin every day. Can you explain to people now kind of what we think about aspirin and who should be thinking about it?
Yeah. So for most people, if you've never had a heart attack or a stroke, you probably don't need to take aspirin. That being said, if you've been taking aspirin a long time, you're like, I've been taking this, I'm doing great, I haven't had any problems, it is reasonable to keep taking it. It turns out, for most people, it doesn't make a big difference. If you're of usual risk and doing the things that you should, taking aspirin is unlikely to prevent something. It's also unlikely to cause a problem, but it can slightly increase your risk of developing like a stomach ulcer or some other issues. But most people, if you've never had a heart attack, you don't have evidence of coronary artery disease or other blockage in other arteries, then aspirin generally isn't thought to be helpful.
And another topic we haven't touched on that I also would love to hear your thoughts on is the impact of insulin resistance in our cardiovascular health. And those patients, we know patients who have type 2 diabetes have higher risk, but the overall impact of even insulin resistance that someone with prediabetes may have in their cardiovascular health.
Yeah, this is an oversight for me. This is something I should have brought up before now, so I'm glad that you've circled us back. When we talk about these things that increase our risk, we talked about blood pressure and lipids and tobacco and weight and exercise and what we're eating. But certainly glucose levels and insulin resistance is another one of these key factors. So most individuals have higher risk the more they're exposed to increased levels of blood sugar. So if your blood sugar is higher than it should be for a short time period, that's worse than if it's always normal. If it's higher than it should be for a long time period, that's worse for your arteries. And if it's really, really high for a long time, that's even worse. So insulin resistance and elevated glucose is really damaging to your arteries. And doing usual things to minimize the risk is imperative. It's something you just need to do. So it's all those same triad. It's using diet, exercise, and medication for a lot of people to manage that to lower your risk. Certainly, if you have type 2 diabetes, cardiovascular disease prevention should be your number one concern. People don't die from diabetes. People with diabetes die of cardiovascular disease. They have heart attacks and they have strokes. So if you have diabetes, you are in a high-risk group. And so your attention needs to be focused on that of saying, okay, I'm going to manage my diabetes, but I'm going to manage my cardiovascular risk, because that's something that can make a big difference in your long-term health.
Yeah, and certain aspects of things you don't have as much control over. I think cholesterol in general is a little bit more genetically related. Your insulin resistance, although there's definitely some genetic components to that too, you probably have a little bit more control of getting yourself more insulin sensitive with lifestyle changes. So really paying attention to that, I think, is helpful. Along the lines of other lifestyle things that we think about, do you see stress and managing mental health and stress playing a role in heart disease at all?
Oh, without a doubt. If only there was a better answer, because you're like, stress is one of those things. The reason it's stressful is because there's a certain element that you can't control. But using strategies to manage your stress is so important for cardiovascular health. There's not one answer that's like, oh, if you have stress in your life, just do this and this is going to fix it and your cardiovascular risk will be lower. But using strategies, whether it's medication or behavioral strategies or exercise, I think a lot of people manage stress with different exercise, whether it's aerobic exercise or yoga. But having a strategy to really work on that can make a big difference for your health.
Well, Dr. Kotter, this has been a wonderful talk. I feel like you've really helped us to better understand cardiovascular disease. And so I kind of want to summarize some of the things that you said that I want people to remember from this. And one is when you are going to your visit with your doctor, whether this is your primary care doctor or your cardiologist, make sure that you have a clear goal of what you're wanting to get out of that visit. And if you have questions, make sure you've written them down. I have actually started writing them down in my phone. Wherever I put it on my calendar, there's a little place where you can make notes, and that way you can find it when you're at the doctor. Another thing is to make sure that you understand your family history. And the main things to think about are, has somebody in your family had a heart attack, a stroke, or an unexpected death, especially if they're less than 55? So that's really what you want to know about. Someone that's had a heart attack in their 90s, probably not something you need to worry about as much. And then realize that you do have control. So it may feel scary sometimes when you know that you have heart disease, but when you combine the advice from your doctor, your medications, your diet, your exercise, all the things, you can still live a wonderful life and you still have a lot of control over that. Some lifestyle changes that Dr. Kotter really stressed. Number one, please stop smoking if you are. And we know that's hard, but really try to look into the resources that are out there in the community to help you stop smoking. Diet, really focusing on whole food diet, reducing those added sugars, reducing those ultra-processed foods, and more plants. If you need more information on this, go back to our nutrition episode. Also exercise, so really trying to get a balance of cardiovascular exercise and strength training, and watch your blood pressure.
All of this is great information. And kind of based off this, we're going to do this week's challenge. So we wanted to announce what that is going to be. And I really encourage everyone to consider doing this because you'll be surprised. We want you to engage in what we call NEAT activities. That's non-exercise activity thermogenesis. And these are the activities that are a part of your daily life that get you up and moving. And I would love to see everyone do this 3 times a day, thinking of a different activity, whether that's parking at the end of the parking lot to walk into a store, taking the stairs instead of an elevator, standing instead of sitting, even fidgeting. All these different activities can add up and improve your health. So give it a shot. Let us know. Tag us on social media. Kitty and I will be doing these as well and encourage you to join us in this week's challenge.
And let us know if there's anything about heart health that you wish we had covered, and we can make sure we cover it in future episodes. You can always reach us if you click on that link that says send us a text, or email us at contact@thestartinggatepodcast.com.
And please join us next week. We're going to take a deep dive into hypertension. We have a special guest who specializes in hypertension as well as its impact in kidney disease, and that is Dr. Katie Donaldson from the University of Kentucky. So we're excited to have her next week.
See you next time.